where I live, just in this group of houses to the left of the break hall there. That's Ballina, similar to the name over near Eastleigh on your west coast. It's spelled the same. It's a small community in northern New South Wales. We're 1 hour short of the Queensland border. We're probably about 10 beaches south of Byron Bay. There's a picture of me with a little visitor that came just outside our office, and I was trying to keep a respectful distance away from the wildlife, and the little koala came and ran up and stood right next to me. So that's actually, when I look at this photo, it reminds me, and Quincy, we've been Facebooking friends back home, and my mate Marty spoke to me the other day, and he told us the unfortunate news that Mary's husband Bob had died. Do you shorten Robert to Bob? Yeah, Robert. Yes. So Bob had died. Now Mary's well into her 90s, and these guys have been married for, somewhere around 60 years, and Marty rang up. He works at the North Coast Advocate, which is our little newspaper that services our town here. And she rang up and wanted to place an ad for Bob in the obituary, and it was pretty sad. And Marty was a bit shaken up. And she said, Marty, I want to place an ad. Bob's died. And he's gone, oh, Mary, that's terrible. He's gone, look, you're paying $50 and you get 250 words. Bob's died is a pretty short obituary. You've been married to Bob for 60 years. Bob's 90. We all know Bob. Is there something you want to say about Bob as well? And so Mary's a bit silent there for a while. And this is what Marty was telling us. He didn't know whether to laugh, but it'd be quite sad. He said he waited there for a good 5 minutes on the phone, and he heard a crackle, and Mary came back to him, and she said, yes. Bob has died, boat for sale. Can you see it fits into it? Look, I've got a slideshow. It's a very small one. I want to race through it, and I was going to apologise for racing through it too quickly. And I said, look, I'm going to do this in 10 minutes. But then I think with you guys, this might be a little bit slow. So I'll speed up if I can. But before, I thought I'd start off with a bit of nursing blues, because you're saying you're seeing problems, and I feel really sceptical sometimes, and it's really important to frame problems as opportunities. And internationally, there's a whole lot. I just want to talk about the panel assessment, but it's the opportunities that present the challenges and the conundrums. And I wanted to spend a little bit of time today not bringing solutions, or certainly I'm talking about the blues, but it's really about those opportunities of unpicking some of them. But there's some real things that hang around and haunting us, I think, and slowing us down. When I said to Mary, what I want to do is really approach it as I would approach my clinical practice. I'm a mental health nurse practitioner. I mainly work with people with autism, work across the lifespan, but really child and adolescent mental health is my origins. And I'm on the board of editorial board for JCAPN, Journal of Child and Adolescent Psychiatric Nurse. It's sort of my passion. And I've been playing around with using and evaluating narrative therapy with kids with autism. And one of the things about narrative therapy is the mantra that just because problems are serious, you don't have to be serious about how you work with them. And there's some other things about externalization, which is untwirling some of the balls of string that present themselves and finding a way to concretely work through each of the issues that present themselves to find realistic solutions. So I just thought I'd start off with some nursing blues, even though I apologise for it being blues. So this is the nursing blues. I come here without any news. Hence I said I've got nothing to tell you. It's just a sense we've got to have another look. Can be pragmatic, we don't need another book. We keep using the advanced metaphor without clear idea of what for. The issue of time and volume and how exercise me in terms of the learning stuff. Mm-hmm. There has to be coherence between the three. When this is only my second live show with the ukulele. The first one I presented, I used a soprano ukulele, which is really cool. I was at the ICN conference, and it fitted nicely under the lectern, and I pulled it out ready to play, and I realised that when your hands are shaking, the frets are really small. So I had to get a bigger ukulele. So I want to consider a little bit about the language and the context of precision we use, but not only about how we talk about nurse practitionering or advanced nurse practitionering, but about being clarity of what's the work to do within our profile of nursing and who's going to do that work and how we're going to evaluate it. This is some of the things that exercised us in our work with standards. I led the team to develop the registered nurse standards for practice. Most recently, and before that, collaboratively with Tom Buckley, we led the team on the nurse practitioner standards for practice. And it was about balancing what's realistic to achieve matched to different volumes of learning. And where in a nurse practitioner as process from novice to developing expertise, we can expect that sort of thing. And I'll talk about it just a little bit in light with scenario-based modelling, and I will have a go at the word advanced because I get very stuck on advanced as a directional metaphor. Once we've done that, I was hoping to get the whiteboard and actually start thinking about some of the string of thinking that we've developed in terms of nurse practitionering and how we might pull some of those strands apart, particularly in terms of what to expect and when to expect the capabilities and the competencies to be able to show themselves, and match that to the volume of learning. And we've had a clear discussion as we've bounced around with the things we're going to put into the master's size box and how we're going to fit them is there. Before we start off, I sort of just wanted to do a bit of a Dr. Seuss, usually I've played, I'll just read this. The patient lay steaming, frustrated and screaming. All he'd asked was who's doing my care, and 2 nurses stood preening. I'm an APN, a nurse practitioner, said nurse 1. I'm an APN too, announced nurse 2. No, 2 MPs thought the patient, this all makes sense, but then come the explanation, it was way too dense. I'm an MP, said nurse 1, and I'm a consultant, said nurse 2. You could put specialist here in Ireland, could you know that? The patient was so frustrated they began to turn blue. Please, said the patient, just do it now. What will you do? Just tell me how. Nurse 1 glared down, but it should all be clear. 2 things can be one, and we are both here. I can order tests, prescribe and refer. Nurse 2 said, I can't do those things. Consult. Specialist, perhaps, I prefer. Nurse 1 said, I can lead your episode of care. And Nurse 2 opened their mouth, but the patient was in despair. If we just talk scope, what can be done is clear. The patients will know that which is dear. Who will do what? The patient at last shouted. Nurse 1 and 2, their advancedness had flouted. I'm a registered nurse, at last, said Nurse 2. I'm an MP, said Nurse 1, so you should know what I do. The patient relaxed, as will planners of service too, when it is clear what worker will do the do. Unlike the Sneetches teachers of stars and beaches, it's important to know what is in each worker's reaches. We looked at this notion of advanced and all the titling that we're using in nursing, and the good thing about Ireland is you're really stuck to 3 titles: registered nurse, CNS and nurse practitioner, but I would bet you know, a few pints of your best Guinness that you'll find the same thing. Is the community of understanding of nursing hasn't kept pace anywhere with contemporary nursing. I have to apologise, I keep using nursing in Australia. We've split the disciplines. So midwifery, even though it's under the same book, is a separate discipline. And so, you know, some of the popular images I just pulled off the web without too much trouble of what nursing is. So the word advanced is just a foundational metaphor. It's a directional metaphor, and it really fits in with what we all want to do. As part of our Western philosophy of living is this constant notion of needing to progress, you know, to get a bigger car, a bigger house, more money, a better job. But it's really just talking about the flowing of reality and a movement forward. If people don't understand nursing, using the title advanced doesn't mean a lot. Because if we go back and look at some of these images, advancing from that's not going to tell someone I can wash a patient better, I can wash a patient without feeling too posh, I can, well, we won't even go into the rest of that. So nursing is responsible for articulating and disseminating clear definitions of the roles nurses engage in and the scope of practice. And that really gets down to being really clear about what's the work to be done. And it gets clear to our thinking when we start to line the 3 things up. What's the work to be done if we think of Anne-Marie's talking, and what are the priorities within that work to be done? At the moment, it's jumping up, but that priority is really a clinical focus attribute. It's about setting up or participating in clinics and providing a full episode of care that allows to avoid hospital admission or to get out of hospital quicker, to save finances, to intervene earlier to prevent chronic disease emergence. And so the primary KPIs, even though we talk about leadership, service design and research, the primary KPIs tend to be resting in the rhetoric of the discussion. It's not rhetoric, in the vision around that area. So when we talk about positions, what RNs are doing, what CNSs are doing, what nurse practitioners are doing, it's about being very clear about what we expect and want from those positions. And then that allows us to think about things like capability development. So we actually went around and we went to every state and territory and conducted focus groups with consumers to talk about what they understood of nursing, but also about person-centred care and how they saw themselves. And we found two really interesting things. One is separating below registered nurses, and other nursing positions was beyond every focus group. And in fact, nursing was just one blob. Now that's kind of scary when you think just over 2.5, nearly 3% of the Australian population are a nurse in some sort of form, and that is also matched in America. And so when you look at population sizes, that's huge volumes. Now, those nurses are assistants, they're registered nurses, they're a whole range of things thrown into one, and people aren't discriminating. When we talked about person-centred care, we found something really interesting is that people told us, look, we're really busy, we're really stressed, we've got to think about our mortgage, we've got to think about our children, we've got to think about what service we can get for our husband who's elderly and unwell. If we can think about one less thing, that's really important. We don't have to think about arranging our care. We don't have to think about this stuff because we've got a GP. We just have to ask a doctor, and a doctor will tell us who to see. And that's a very much pervasive thought in the Australian society, and I wouldn't be surprised if that translates internationally. And so when we're using concepts like person-centred care, it's thinking also about capabilities, how we position someone to be at the centre of care. And for nursing, one thing that we could really stretch our nation is how we can get into school curriculum and teach people, as they do in Sweden and some other countries, health literacy and how to be at the centre of your care as part of your program. We know that with PhDPE in Australia you don't actually learn to apply a condom or to prevent STDs until you're in year 10, year 16. Yet we know from the stats, horses bolted in many cases way before then. So there's something about teaching people to be at the centre of care. Often people say we'll do demonstrations, we'll do trials, and we'll build evidence, and that's really important in light of policy work, which is Anne-Marie's talking about. But in terms of whether that's going to change anything, actually the evidence suggests that it doesn't matter how much evidence you've got, it's not going to change your barriers to practice. So as a bit of an exercise to explore that, we sat down and we mapped, and it was a very quantitative approach, and it's not my only bias, but it does give you a very easy way to do it. So we matched RCTs and systematic reviews of nurse practitioner efficacy, safety and quality of care and cost effectiveness against barriers to practice. And lo and behold, the frequency of reporting of barriers to practice hasn't reduced despite the building of obvious evidence that nurse practitioners at master's level are as safe as their medical colleagues in the provision of care within the scopes that have been researched. And in fact, they're no more expensive. There's this myth in Australia that, well, what if they're more expensive? When we actually looked at the few economic analyses there, we found a few things, but one was this really interesting assumption, because economic analysis is based on assumptions. And the study that found nurse practitioners more expensive, of course, had the assumption that doctors were free because you can't do without a doctor. So therefore, any service with a nurse practitioner was adding the value, the wages of the nurse practitioner. So nurse practitioners become more expensive. So there's no research that nurse practitioners are any more expensive. We know they're just as safe and they're quality. And we've got enough evidence around the world not to need to keep collecting it to persuade people to reduce these barriers. And so the barriers won't just go away with evidence. And one thing we've learned from experience is the support of medical colleagues won't come with evidence. It won't come with building good faith. It won't come because it's about protectionism, protection of power hierarchy and protection of financial security. And nurse practitioners threaten all of those elements. And so that was just an interesting thing to think about. It comes into scenario-based modelling, of course, and our health workforce, just as your health workforce, is using scenario-based modelling. Scenario-based modelling, of course, comes from scripting, straight out of Hollywood. That's where the whole thing emerged. And so in this script of healthcare, who can do what? Now, that's why it's very clear, why we have to be very clear about what work can be done with who under what circumstance and what capabilities, concrete capabilities, people bring at different levels of practice. So basically they form a script as the, Bob's sick, he fell off the bus, he broke his leg, he comes off the bus, who can do something? And then they add all the, well, these people could do this stuff. The scary thing, of course, is that the decision makers, the people who are doing this policy work, actually, from the research, don't have a whole lot of skills. They don't have the skills to read research. So that table I gave you isn't something they'd access and go, well, I'll go and look at all the RCTs on the effectiveness of nurses or midwives. They actually go back to what I said a few slides ago on their community understanding of who does what in healthcare. Yeah. This is what nurses do. So you'll get to watch the guy and you'll get to put the bandage on at the direction of the doctor. So that's getting clarity around what we're talking about and selling that message is really important at that really policy, sort of level. In Australia, when we got access to community stuff, and my head was racing off because I work in private practice, and so I'm not employed by a service. I'm not even employed by the university. When I got my chair at this university, part of my negotiation was I practice clinically, and that all was, yeah, come and do that. And then we hit a hitch with, well, how do we actually ensure an academic to do that? And so they asked me if I'd re-establish my private practice, because then it's clear, because then they can, I can rent the room if you like, and I have my own indemnity insurance and things, but I'm not employed by HSIE or a health service or whatever. And in fact, to have more of me, students should be able to come from that model as well, which means that they're not embedded, and I need to have clinical supervision, so I have to source it. Now I'm stingy as, I don't like spending money. Maybe I've got some Scottish genes as well. So I have peer supervision. At different times I've had group peer supervision where other mental health nurses come, we go through cases and we do it collaboratively. At the moment I'm having individual peer supervision with another person, and we do the same. And so how I source it and how I can demonstrate it is on me, and I have to do it, but it's thinking about who provides what, and it gets down to that sustainability. To be able to do that, we got access to the medical benefits system, which was a great coup. We had to have parliamentary roundtables. First, we formed a policy coalition. We went off. We had roundtables. Then we got a consensus agreement of something like 23 colleges of nursing and universities. We eventually changed the legislation with the will of the health minister. We then went through how we're going to implement it. We had all these working parties. At the end of the day, we'd got access, and I went off to the bureaucrats to work out. And one thing we hadn't paid attention to, of course, was the value, money value they assigned nurse practitioner service. Now, of course, think back to policymakers, their view of what nursing does. The driving idea was nurses could never be paid more than a junior doctor, so we'd have to give them no more than 2/3 of what a junior doctor would get for an hour of service. You're talking about, residents who are doing rotations. And so along this bar graph, can you guess which one is the nurse practitioner's hourly compensation through the medical benefits scheme, which is actually the patient's reimbursement, so it's not where you get these out-of-pocket expenses bigger. Guess which one of those, when there's a mix of allied health, registered nurses, and nurse practitioners in there. While we're guessing, I'll just ask, has anyone online got any questions so far? No. Okay, so rushing through this so we can get to the juicy bit. Did you have a...
They're always fun.
Yeah. Exactly. Yeah. And do you know what? These are registered nurses who actually get paid more under a different scheme. Now, this is a clinical psychologist. A clinical psychologist has a master's degree, and they're regulated by our board, and they have a very similar hour of practice, supervised practice requirements. And this is a nurse practitioner. This is purely based on that policymaker's decisions about the relative money value. And so when we talk about barriers and enablers, it's good to put extra candidates into the pipeline and hope that the pressure in the pipeline builds up and knocks the barriers away. But some of those barriers are way beyond nursing's control, and it gets back to some of that thinking of unwinding exactly what we mean by what works to be done by whom and when. So just to finish off with our patient. The patient said, "Phew, I know who is nurse 1 and nurse 2. What is more, the plan and you too. We all know what is done by nurse 1 and nurse 2, the two lovely nurses who certainly do the do. As well as scope, volume of learning must be clear, so we can all understand the nursing profession we hold dear." So you must be wondering about the so what of this reflection. I'll clear my throat and tune my inflection. It's their necessities of NP capabilities. It's how they hang together cohesively. Bird must go with feather. I mean, their necessities of NP capabilities. We need the courses that bring the capabilities to life. But there's more. It's the bare necessities to develop MP capability. The label on the tin must clearly match what's within. I mean, the bare necessities of MP capability. We need to get the education right to match the opportunity.